use the term medical neglect. I know those are strong words, but I believe strongly that when a child does not get the care that they need in the physician's office, that is medical neglect. Now, medical neglect is typically referred to as a parent who does not bring their child to the physician when it is warranted. But in this case, I use it as a term to describe a physician who does not, conduct the proper care for a child. So a little bit about my practice, right? As I mentioned, I specialize in the biomedical treatment of children with Down syndrome and other special needs. Now, biomedical treatment, you might be wondering what that is. We look at a lot of very in-depth biochemistry to help understand the root cause of health issues, including cognitive and speech delays, developmental delays, anything from skin rashes, gut issues, constipation, sleep issues. In our children, we run testing on our patients. We do very thorough history exams in order to get to the root cause of their issues, and we certainly do not succumb to diagnostic overshadowing. So where this journey started and where it has taken me, it started with the birth of my own son, who does have mosaic Down syndrome, and I started researching and looking at research that exists into the biochemistry of having the extra chromosome and what proteins are generated potentially in higher amounts in individuals with the extra chromosome and how that can impact their biochemistry. And so that's where I started my practice in helping my patients, and I wasn't finding that it was helping patients as significantly as I would have liked. When we did work on methylation and many of the issues that research shows that quote-unquote children with Down syndrome have, and where I saw the most improvement in health in my patients is when I looked outside of the extra chromosome, and I looked at them as a child first, and we looked at their issues of hypothyroidism and gastrointestinal issues, and when we started to remedy those conditions, that's where I saw the most improvement in my patients. So I do not follow the general accepted paradigm that the extra chromosome is necessary pathological, right? I know this is a little bit outside of the box for many people, but I believe that children with Down syndrome are not to be fixed, that there is nothing quote unquote wrong with the extra chromosome, and this avoiding diagnostic overshadowing is one of the biggest ways that we help our patients. So I wrote a blog post about it. If you'd like to go to our website, it's www.pearsoncenter.com. And if you'd like to read about this topic, I've written about it as well. And I include another story of another patient here who very obviously, what I wrote here was the most obvious case of diagnostic overshadowing I've experienced. So I highly encourage you to take a look at this blog post and read her story as well. I'll share another one here in a little bit. So I'm going to talk about, I'm going to define diagnostic overshadowing, why it happens, give some examples. This was very difficult to pull out just one example of this happening in a patient, because literally this happens in just about every single one of my patients. Consequences of diagnostic overshadowing and certainly how to prevent it. So it is literally defined as the tendency for clinicians, now this can be physicians, physical therapists, speech therapists, to attribute symptoms or behaviors of a person with intellectual disability to their underlying cognitive deficits, and hence to underdiagnose the presence of comorbid pathology. So if a child is acting in a certain way, exhibiting certain behaviors or symptoms, that they can very easily be dismissed as just part of their intellectual disability, when in fact there could be something significantly wrong. The child could be exhibiting behavioral issues because they're in pain. They could be cranky, irritable, stubborn because they have headaches, or there's a problem, they're tired, there's sleep issues. And so many physicians will unfortunately dismiss these very obvious clues that are presented to them during appointments. And so this is truly what diagnostic overshadowing is. This was not something that I discovered. This was not something that I made up. This was first coined in 1982 by Dr. Stephen Rice. He was a professor and researcher in clinical psychology at Ohio State University, and he studied this phenomenon in individuals with schizophrenia, I believe it was, and the term was first used in those with mental health and now is extended to include those with cognitive disability as well. So why does this happen? This is a difficult topic. I'm certain I'm going to perhaps put out some ideas that are either different than what you normally think or contradict what you agree with. But these are some ideas that I have researched and read about elsewhere and are presenting to you today, some of my own ideas as well. So discrimination, right? When a patient comes into a doctor's office and is treated differently than if a child without a cognitive disability or a mental health issue were to have, if they're treated differently, then that is truly discrimination. And so if a child, for example, without Down syndrome came into a doctor's office and had all the symptoms of hypothyroidism, delayed growth, constipation, dry skin, they would get a thorough workup for hypothyroidism, Hashimoto's, and would perhaps more readily receive treatment, where many children today with Down syndrome will present to the doctor's office with these same symptoms, and oftentimes, not always, the symptoms are dismissed as just normal for Down syndrome. Another reason this occurs is lack of training. I'll get into some in-depth data about this actually, where physicians are not trained in signs and symptoms to watch out for in individuals specifically with Down syndrome, autism, how to work with individuals with varying communication, modalities and differences. And so there's some specific kind of ways that we work in our clinic in how to work around a child's behavioral issues or cognitive issues or speech delay, etc. And then there is a certain level of discomfort that is sometimes rooted in the lack of training, rooted in lack of exposure in general in society to individuals with, varying, neurodiversity. And so doctors are ultimately human. We hope that they go into the medical profession knowing that they will be exposed to a wide variety of, races, gender, cognitive abilities, etc. But for many, and not all, there can certainly be just a level of discomfort. Miscommunication, again, certainly we're talking about some patients who may have some communication delays, caregivers who don't appropriately communicate information about the patient, etc. So I'll talk about some specific examples here in a moment. And the lack of or inability to conduct the physical exam. I hear this all the time when I ask parents during my appointments, did your physician do deep tendon reflexes? Did your physician do pinprick tests, thorough neuro exams on this child with Down syndrome who is, it is considered to be a neurodegenerative condition. And so many times these physical exams are not being conducted. And I understand certainly physical exams are difficult on children in general, and there can be some challenges in doing this in children with Down syndrome and other special needs, but you can be as flexible as you can, perhaps even conducting that appointment over a matter of days. I highly encourage you as a parent to incorporate some of this medical exams within your play of your child, getting those toy doctor bags and playing dentist on the dolls and really incorporating into your play and everyday life, I suppose, to make our jobs a little bit more easier as physicians, when we do try to conduct our physical exams. So why does discrimination happen? This is a really difficult topic, right? I'm not going to come up with any answers here. I'm more going to want to raise questions. So specifically, discrimination is defined as the unjust or prejudicial treatment of different categories of people or things, especially on the grounds of race, age, or sex, and certainly of cognitive or physical disability or differences. So just some questions you should ask yourself, I think, that are really important. What makes a person valuable to society? Is it their ability to work and contribute in a physical kind of, to make something or build something? Is that how they contribute to society, or is there something more in depth? And then some people would even argue that we shouldn't even ask this question. Just somebody's mere existence in the world is enough. I think that we are all here to learn from one another, and what we learn from individuals with Down syndrome and other, cognitive issues and neurodiversity is huge, right? That we learn compassion and we learn to value our differences. And so I think that there should be a place at the table for individuals, certainly with neurodiversity in mind. And so what actually defines a disability, right? There's a huge range here. I personally have vision issues. I have a very strong prescription, and if I were to want to join the Air Force, let's say, or be a pilot, I wouldn't be accepted, and my vision would be considered, perhaps a disability. And so there's a huge way that we can define disability, and so many people who one person might define as a disability, that person might be able to, conduct their lives in a very similar way, and be very independent, and it not actually, be a disability. And so again, more questions to ask yourself. What does the word disabled automatically conjure up? Are these images of someone who is unhealthy, right? Does somebody with a disability, what does that look like to you? What does Down syndrome typically look like to you? Is that somebody who is healthy, unhealthy? And again, these are just questions to ask yourself. Are there preconceived notions that you have on what these diagnoses and how they define a person? I hope not. And so causes of discrimination, right? Again, this is tricky stuff. These are deep-rooted psychological suspicions of just things that are different, ambiguous, inexplicable. These are unfortunately innate. How we notice differences in people come up very early in childhood. Children will ask, mommy and dad, why is this person different? And so it's something that is noticed, in all of us very early. So teaching children about the value of our differences, and not only our skin color and our race and our gender, but certainly in our cognitive and physical disabilities. And again, this kind of speaks to the lack of inclusion in schools. I would argue that our classroom is a microcosm of society, and if we remove individuals with, again, quote unquote, special needs from a classroom, what does that tell those children who remain in the classroom? That that's okay? To remove that child from the classroom is like removing them from society, separating them. And so I would argue that all children have special needs and learn in different ways and have different behavioral needs. And so certainly inclusion within the classroom is growing. We've got a lot of work to do, and in order to help children accept that we can have a wide variety of, again, neurodiversity within a classroom. Unemployment, again, speaks to the same, just not having the presence of individuals that we see in our everyday lives, lack of visibility of those with Down syndrome and autism and other special needs. And so again, there's certainly a growing movement here, but there's a lot more work to do. And again, ultimately, doctors are human. They are going to bring our societal acceptance or definition of what it is to have Down syndrome and autism. They're bringing that into the office. And so unfortunately, the door of the doctor's office, discrimination does not end. And so unfortunately, this continues within the exam room of many doctors' offices. So lack of training is definitely a cause of diagnostic overshadowing. In 2009, there was a survey of medical schools, and over 50% of deans reported that disability training was not a high priority, right? There's a high medical need in the disability community. And so if they're not making it a priority in medical school, then doctors just are not going to be prepared to help these patients. However, 61% reported their graduates were competent to treat those with a disability. Now, certainly doctors are, receiving medical training, but there are some differences in how we treat these individuals and how we speak around them, how we work with them within the, exam room. And so as a result of this, 81% of medical students reported no clinical training. Seniors and graduates expressed inadequate competency in the care of patients with disabilities. They left medical school ultimately feeling unprepared, and I would argue that that is accurate. This came from a journal that was published in 2009, Preparing Health Professionals to Provide Care to Individuals with Disabilities. So again, one could argue that there is a growing population of those with disabilities in the United States. In 2010, of the almost 54 million school-age children in the U.S., 5%, a little bit over 5%, were reported to have a disability in 2010. One would argue that the growing epidemic of autism is going to contribute to this percentage increasing within our communities and within our schools. And so, are we trained enough at all to serve this population? I would argue not. There is definitely a lack of training around autism and Down syndrome and other special needs within medical schools. So what happens when these physicians and other healthcare practitioners don't receive the proper training, right? They underestimate the abilities of patients with a disability, right? With the proper training and the proper understanding that a person with a disability can actually, understand a lot, can actually do a lot, can contribute to their own health care. There can be a better understanding, and they can, not do this perhaps. So without training, they will grossly underestimate the quality of life of patients with disabilities, right? Many patients live very happy, healthy, thriving lives, right, with jobs and relationships and, living independently, many of them. And so, again, breaking some stereotypes here within even the medical community is very important. And they will minimize the patient's capacity to contribute to their own health care. Again, that leads back to their abilities. And they will minimize the extent and importance of the patient or parent's expertise in the condition. I want to pause here. Many of you parents out there can relate to this question. If you go into your pediatrician's office and you have a patient with Down syndrome or autism, you oftentimes will have more knowledge, even biochemically, and the research that's out there on what it means to have that condition. And you are more oftentimes an expert than that physician, and it's really important for that physician to acknowledge that, recognize that, work with you, maybe read the research that you present with them, so that they understand, at as deep a level as you do on how to help your child. And so again, without the training, they might believe that a person with a disability cannot be healthy. Physicians just aren't getting the proper training. This image here that I put the red circle through is an example of what a physician might see in a textbook, right? These are all the negative consequences, and they're taught that children with special needs are just a constellation of symptoms and risk factors. They're not taught that children with Down syndrome are often cherished and loved and can live healthy, happy lives when their health issues are properly addressed and when their health is optimized. And so medical school training and society reinforce that disability, unfortunately, can be unhealthy. I mean, all these symptoms here on the left speak to a child that is unhealthy. And many of these symptoms here that you see can actually be attributed to their hypothyroidism and is not actually Down syndrome. Many of these symptoms you see here can be attributed to nutritional deficiencies that do occur in children with Down syndrome. And so this is definitely a very limited view of what it means to have Down syndrome and special needs that doctors are getting in through textbooks. So I put this meme out there a while back, and it got shared a lot because I believe many people agreed with it. So no one suffers from Down syndrome. What they suffer from is a society that doesn't value their worth, resulting in doctors who aren't trained in how to optimize their health by addressing the root cause of biomedical imbalances. And so we often see research papers and articles saying that this child suffered with Down syndrome. Nobody suffers with Down syndrome. What they suffer from is their constipation, their sleep issues, their breathing issues, their health issues that are often attributed to something else outside of the extra chromosome that doctors are missing. And so, because physicians are not trained in the possibility that a child with special needs can overcome health challenges and that their potential is a lot more unlimited than history has deemed it to be. Like this healthy child here who happens to have Down syndrome. I often use that term. It's a child. She happens to have Down syndrome. She's happy, healthy, thriving, intelligent, and I see great things for the future of this child for sure. And so they're not taught that children with Down syndrome can actually be quite healthy. Another example of advertisers using, fortunately, children with Down syndrome a little bit more so that we see them more within our everyday environment, and hopefully that happens more and more in our future. So in 2011, a team at Children's Boston Hospital surveyed parents, guardians, and siblings of those with Down syndrome, 2,044 actually, quite a few. 99% of them, nearly all of them, said, of course, they loved their child with Down syndrome. 79% felt their outlook on life was more positive because of their child. It's a huge shift in a person's perception of the world, and the importance of kindness and love. And so it can really shift your perspective. So my ultimate message here of that 79% is that they benefited, from having a child with Down syndrome in their life, right? These parents, they didn't feel it was a detriment to their life. Only 5% did feel embarrassed by their child, and 4% regretted having their child. I hate to put those statements there, but my point is those percentages were very small. And the discrepancy between the reality of what parents experience of having a child with Down syndrome and what doctors are reporting that they will experience if and when having a child with Down syndrome is very different. When that physician who is reporting what it means to have a child with Down syndrome, when they are delivering the diagnosis, when that doctor may not ever have met someone with Down syndrome, doesn't know what it's like to live with someone with Down syndrome, that the experts are truly the parents, and here the survey reveals what they're actually feeling. So they also interviewed siblings, 822 of them. 94% expressed feeling of pride about their sibling, right? Again, there's this thought, this myth that siblings of a child with Down syndrome will somehow, suffer themselves because, they have a sibling with Down syndrome, and that's definitely not the case. 88% said they felt that they were better people because of their sibling with Down syndrome. Again, they benefited from that. Small percentage felt embarrassed, and an even smaller percent, wanted to trade their sibling for another. Okay, but again, a very small percent. So, getting back to another reason about why diagnostic overshadowing happens, there's a miscommunication. Patients who are nonverbal, who have delayed verbal skills, cannot relay their symptoms. Now, this is many children in general, and certainly if there's a speech delay, they will not be able to, perhaps express when they're in pain or discomfort. And so this creates an obstacle. And so a well-trained, perceptive physician should be alert to signs of pain and discomfort. This is one of the biggest things that I try to pick up in my patients is their behavior rooted in pain? It's one things I absolutely do not want to miss. And so there are many signs of symptoms of pain. Is the child, laying on their abdomen, bending over the furniture, pressing on their abdomen, pressing on any body parts? Are they doing any self-injurious behavior? I guarantee those are symptoms of pain. Self-injurious behavior, even biting, right? Pulling their hair. Those are signs of pain, not just normal aberrant behavior, right? Behavior that is expected in autism or Down syndrome. And so unfortunately, the threshold for pain can be increased in those with intellectual disability. Now, this can happen because of neurological issues that they are experiencing, neuropathies that they're experiencing, where their nervous system is not as kind of engaged and functioning. Again, this is often rooted in nutritional deficiencies, vitamin deficiencies, but they can have an increased threshold for pain, which will, cause conditions to get missed. This has happened to me where the caregiver present at the appointment may not know the patient well. I've had adult patients with Down syndrome who come to the appointment with their parent who does not live with the patient. They actually live in an adult facility or a home where they, live very independently with other friends. And that parent may not know a lot about their daily life, even their diet or their, bowel movements. And so there's a lot that can get missed in what's going on with that patient. So consequences of diagnostic overshadowing: untreated medical conditions that perpetuate the intellectual or physical disability or even cause it, right? Again, the gastrointestinal issues that happen in children with Down syndrome and autism are often the cause of their cognitive and physical disability. If we don't address them, they will, make things worse. A decrease in quality of life. If you miss pain in a child, you are absolutely decreasing their quality of life. They are continuing to be uncomfortable. the lack of sleep, or if a child has sleep apnea, they're going to be, tired during the day, and they will have an absolute decrease in, I believe, in certainly the quality of life. And unfortunately, the extreme end of this is premature death. I'm going to share with you here a story from Australia. This was reported in the Sydney Morning Herald in February of 2017, why people with intellectual disabilities are dying avoidable deaths. Now, this is the website for this journal if you'd like to read this story for yourself. So this is the story of a 28-year-old woman. Her name is Michelle. I'm going to tell you a little bit about Michelle, and I believe what the important part about Michelle is who she was as a person. Right? She loved to sing, wanted to be a copy typist, according to the article. She longed to fall in love like her sister. She was cherished, valued by her family, again, a valued member of her family, and she happened to have an intellectual disability. Now, what happened was the mom presented to the emergency room. She brought her in. She had a fever, significant ear pain, and loss of verbal communication. She was in so much pain she was unable to communicate, and the doctors accepted her lack of verbal communication as normal for her intellectual disability, despite the mother reporting, again, not listening to the parent, despite the mother reporting that this was a change in her child's ability and demeanor. And what ultimately happened was she was diagnosed with a temper tantrum. Even though she was in so much pain, she lost her ability to communicate. She was given acetaminophen, which is Tylenol, and ibuprofen. Mother was told to take her home. And the mother actually ultimately refused to leave without her daughter being appropriately assessed and treated, and the hospital security was called instead. She was escorted out, deposited into a wheelchair, pushed into the curb, into a taxi at 4 a.m. So the mother, brings her home. Michelle had happened to have a seizure as well. And so in case she had another seizure, the mom put blankets on the floor. Imagine the fear in this mother, bringing her so visibly sick child back home with just acetaminophen and ibuprofen. Unfortunately, her brother did find her a few hours later in the morning. Her lips were blue. She had died of cardiac arrest, secondary to meningitis. Right? The doctors did not conduct a thorough exam, did not get the warranted CAT scan that would have detected meningitis or do the proper testing to detect it. And they concluded the diagnosis of tantrum was completely inappropriate, both because it was offensive and because it does not designate a medical condition. That was the coroner's words. And so this is an extreme example of a case, but this is one that is now in the public eye. And my guess is that this is not the only example of this sort of thing happening. And my hope is that we can prevent it from ever happening again. So I have a story of a little boy who came to my practice. He was 3.5 years old. He had Down syndrome. T21 is trisomy 21. Has Down syndrome, and he was not walking at the time. 3.5 years old. Now, again, a typical child comes into a doctor's office at 3.5 years old, not walking. They're going to run a battery of tests. They're going to try to figure out what's going on with this child. But because this child had Down syndrome, nothing was done. It was accepted as normal for Down syndrome. He's only 4-point crawling. He did happen to also have nystagmus, which is a kind of a shaking of the eyes as he looks around and moves his eyes. His speech was fairly significantly delayed. He only had single words like eat, play, and ball. He did have hypothyroidism that we ultimately addressed with thyroid hormone that was not being addressed by any other physician. And what the mother was reporting, despite his hypothyroidism also being treated, that he was more cranky lately. And so this is something that I don't just breeze over. Parents know this. You might recognize if you're listening and if you're a patient that I pause there and I ask, what are you talking about cranky? How cranky? When? Why does it happen? What makes it better? I want to know more about this crankiness and behavior and really try to understand what's going on with the child. So this is a video of this child. His name is Nathaniel, 3.5 years old. It's a video of him crawling. Yeah, it's running a little bit on the slow side. But yeah, you might be thinking, well, here's a child, with Down syndrome who's crawling. And you might think, well, he has Down syndrome. Of course, he's only able to crawl, but that's the problem. I don't want this to get dismissed as, just Down syndrome. So we ran some in-depth testing. Oh, sorry, here's another example of him of him. There's the mom trying to get the book, trying to get him to walk. And you can see him here. He knows what to do. His body he knows I need to stand up, but he just collapses. And again, by seeing this and watching him, it's very cute. I knew, here he goes. I knew there was something more going on here. And so, so we ran some in-depth testing. And here's what we found. These are the results of his organic acid testing. Now, organic acid testing, I'll tell you right now, is one of the #1 tests that I run in my office. It is the most important test for detecting biochemical imbalances, gastrointestinal issues, mitochondrial issues, and vitamin nutrient deficiencies and more that can greatly impact the health and development of children. And so what we picked up here was elevated levels in his bacterial markers. So he had bacterial overgrowth within his small intestine as well as yeast overgrowth. And this overgrowth was inhibiting nutrient absorption that was contributing to vitamin deficiencies and causing an elevated lactic acid. I'll talk about the specific vitamin that was doing this. I'm not going to go into too much biochemistry here. There's an enzyme here called pyruvate dehydrogenase, and when it's not working, we get a buildup of pyruvic acid and lactic acid. And the cofactors for pyruvate dehydrogenase are vitamin B1, B2, and alpha lipoic acid. So that's really briefly what was going on here. And so this lactic acid is the same lactic acid that we might experience if we have a heavy workout and our muscles are sore. And you saw him collapsing, right? I've had hard workouts where I just about wanted to collapse like that because my muscles were so sore. And so this child was in pain and unable to express that he was actually in pain. That's such a high level of lactic acid. What we ultimately did, oh sorry, there's some more markers here. These elevated alpha keto acids, these are another indication of his need for thiamine. Formiaminoglutamic acid is an elevated here, indicating his need for folate. So he was experiencing some significant nutritional deficiencies secondary to that bacterial and yeast overgrowth in his gut. So not only did we treat the gut dysbiosis, which is the most significant thing that we did. I'm not going to go into great detail here to talk about what we did. That's outside the scope of this talk. But we used some herbal antimicrobials, something to break down biofilm, diet changes, and then we used a probiotic. And so to address the nutritional deficiencies, we also used folinic acid in high dose. That's not actually all that high. We can go much higher with folinic acid often. And thiamine, we ultimately switched them over to benfotiamine. 35 milligrams is not actually all that high in a child who is deficient in thiamine. And so here's a paper explaining a little bit about what we did. It's titled The Etiology and Therapeutic Approach to Elevated Lactate, which he had. And so as you can see here, in the absence of thiamine, which he was deficient in, anaerobic metabolism predominates and lactate production increases. So this child had a thiamine deficiency. Now thiamine deficiency is called beriberi. So what he was experiencing was not Down syndrome. He was experiencing pediatric beriberi secondary to bacterial overgrowth and yeast overgrowth within his gut. And once we address this, right, here are the results of his test. A very accurate test. It's valuable and it's a valid test because we see here the results after we did an antimicrobial treatment to eliminate the yeast within his gut. He still had some markers of some elevations in some bacteria here, but once we clear the majority of that, addressed his deficiencies, his lactic acid greatly improved, it reduced, pyruvic acid greatly improved, still a tiny bit elevated there. His alpha keto acids were down. We still had some adjusting to do of his doses here. We had to go much higher with folate, right? And here's the result. After just a few months of being on the higher dose thiamine, higher dose folate, but more importantly, of clearing the bacterial and yeast overgrowth within his gut, right? He started walking. Now, you might be thinking that, at 3.5 years old, he was ready to start walking anyways. Right, there he is. But at 3.5 years old, these parents had been working for years to help him walk with some very intensive therapies, and nothing helped him until we addressed the nutrient deficiencies. Yeah, it's very cute. So this is a statement from the mother. I'm breaking a rule of PowerPoints here, showing you all this text. Feel free to pause the video if you'd like to read this word for word. They tried many things. Once they addressed his hypothyroidism, he was no longer completely lethargic. Again, no other physicians had been addressing his hypothyroidism. They noticed more when they did growth hormone therapy, and it used to take a lot of motivation for Nathaniel to crawl and try to walk. Now he's everywhere. He has amazing progress in just a few months, going from taking only a few steps to walking almost across the room. Can't wait to see what the future holds for him. So this is an example of a child who, his gross delay in development was all attributed to his Down syndrome, and there was much more going on under the surface. These are some examples of some things that we detect in our office. Candida overgrowth, SIBO is small intestinal bacterial overgrowth, gastrointestinal malabsorption secondary to Candida overgrowth and SIBO, hypothyroidism we pick up all the time in children, and addressing the root cause there is key in addition to medication when warranted. PANS-PANDAS is pediatric autoimmune neuropsychiatric disorder associated with strep, also called post-infectious autoimmune encephalitis. These are infections that can cause significant cognitive issues, brain inflammation, and when detected and treated can make a huge difference for children. Phenol sensitivity, sulfation issues I didn't list here, histamine sensitivity, parasites, and nutrient deficiencies. Again, this is just an example of things that we pick up in children when we do a bit more in-depth history and definitely more in-depth testing and checking for many of these things. So there's an actual curriculum that's out there to teach medical students to care for people with disabilities, development and initial implementation. This was written in 2009. It's a very in-depth curriculum that should be used and looked at more often in medical schools. And what they state here is, reiterates a lot of what I've been saying. Lack of knowledge and skills and negative attitudes toward patients with disabilities may adversely affect the services available to this group and negatively affect their health outcomes. And so negative attitudes towards patients, this happens, right? This isn't just me saying this. This isn't just my opinion. This is shared by many people and certainly, unfortunately, by many parents potentially watching. So tips for physicians. If physicians hopefully are watching this, right, seeing the patient as a person first. Recognize that their diagnosis doesn't define them, doesn't always explain every health issue. This is my patient Carly. Her mother is Kim there. And so Carly, for example, she is not Down syndrome, right? Down syndrome is just something that she happens to have. Just like I happen to have brown hair, you may happen to have blue eyes. It's a part of who she is, but it doesn't define everything about who she is. And so absolutely listening to parents and caregivers. We work very closely with parents, and we take a very team approach. We make a lot of decisions together with families. We educate parents a lot. We see them as a partner in helping their child. We listen very deeply to what their concerns are, their reporting of symptoms, etc. Again, communicating with the patient as well as the caregiver, especially in the case of adult patients. Don't speak about them as though they're not in the room. Right? This is an adult with very high cognitive abilities in many cases, and to be treated accordingly. And so making every attempt possible to conduct a proper physical exam. Now I know there can be many challenges here, and we're always working on this as well. I'm already thinking of some things that we need to start to implement in my practice. A lot of visuals, showing the child what we're going to do. But if you as a parent at home can do anything to incorporate, I think I said this already, medical exams and playing doctor at home and dentist and things, it's very helpful for us physicians. And so physicians, be open to the idea that there's more that can be done to help children with special needs than medical school has taught most physicians. Right? Again, medical school is not training in this root cause, functional medicine, looking deeper, not just using prescriptions to mask symptoms, but looking at why the symptoms are there in the first place, and certainly in individuals with special needs. And seeing the patient holistically, understanding that improvements in overall health can lead to improvements in brain health and cognition. Right? I'm not even only going to say that there's growing research to support the connection of the health between the gut and the brain. We're there. right? We don't need the research. We know that the health of the gut can dictate, brain health, and vice versa, right? The communication of the brain with the gut is very strong and often dictates gut health. And so all of these systems working together and reading them as a whole is very important for physicians. And so I highly recommend that physicians read up on the impact the gastrointestinal dysbiosis and malabsorption can have on a person's health, and certainly on their cognition, right? Again, that gut-brain connection. Learning to recognize the symptoms of nutrient deficiencies that can have profound effects on the development of a child. Now, in developed countries today, and definitely in the U.S., nutrient deficiencies are happening in children. I guarantee it. I believe it's one of the leading causes of autism. That's a big topic, but nutrient deficiency secondary to malabsorption, secondary to overprescription of antibiotics is definitely occurring in children and definitely getting missed. Physicians just are not taught the role that vitamins have in health. Vitamins aren't just a trite thing that we pick up at the local health food store and we take, to help prevent colds and flus. Vitamins have significant roles as cofactors of enzymes within our body, and doctors need to do a little bit of a better job, as I see it, in recognizing what those nutrient deficiencies look like and how they can contribute to the child's health. Studying the symptoms of hypothyroidism, right? The hypothyroidism affects every organ of the body, every tissue and cell of the body practically. And so, dermatologists need to know what hypothyroidism looks like in the skin. Dentists need to know what hypothyroidism does to the teeth. Neurologists need to know what hypothyroidism does to the nervous system so that hypothyroidism can get picked up, especially in those with Down syndrome. And then hopefully physicians will gain an appreciation for epigenetics, right? Especially in the case of children with Down syndrome, and understanding that our health is not dictated by our genes alone, right? Again, children with Down syndrome are not simply divined biochemically nor personality-wise. They're all different. This is one of the biggest messages of my practice. If you have a room full of children with Down syndrome, it will become very evident very quickly that they all have varying abilities, just like the rest of us, in their cognitive, gross motor skills, fine motor skills. And if the only thing that was dictating their health was that extra chromosome, then we wouldn't see this huge variation in their health and abilities. So to me, it became very evident very quickly in my practice that there was something more going on. It wasn't just the extra chromosome. There's, if you have a child with Down syndrome who is experiencing significant delays and having significant issues, there's potentially something that is being missed, because there are many individuals with Down syndrome who are healthy today, and many adults who are thriving. Pablo Pineda is a good example, Karen Gaffney, the young adults who are on the A&E show, Born This Way, all examples of very healthy individuals with Down syndrome, and there are many others. I ask you to question why it is that those individuals with Down syndrome, with the extra chromosome, full copies, why they have been able to be healthy and thriving while other children with Down syndrome are struggling, sometimes in very significant ways. I say it's something other than the extra chromosome, and in many cases diagnostic overshadowing is hindering the health of those children who are struggling. All right, so tips for parents, right? Don't let a doctor do this. Don't let a doctor say that that's just Down syndrome or whatever, or autism. And if they do, go find another physician, right? If your physician is not willing to help you and is just dismissing your symptoms, go find another physician who will. We certainly will help you at the Pearson Center for Children. There are good pediatricians, good functional medical physicians out there, and I recommend that you seek one out. Really understand that your child's potential is much greater than has ever been thought possible. And if your child doesn't seem to be reaching their fullest potential, as I mentioned, seek out help, for someone who will look at the underlying medical reasons outside of the extra chromosome or diagnosis or autism, etc. So these are the words of Dr. Sid Baker. He's a pioneer in the biomedical treatment of children with autism. Children with autism are being recovered today. And a lot of the work that physicians are doing today are thanks to physicians like Dr. Sid Baker. And so he has stated that parents will frequently tell him that their kindly pediatrician has responded to their plea for direction with the question, "So you think you can find a cure for autism?" And the parents say, "No, through angry tears, we just want to help our child." And so again, this was an example of, how diagnostic overshadowing can happen. We love and accept our children when neurodiversity is definitely an important part of society. We need to honor and neurodiversity for sure. We can do this at the same time. We can love our child at the same time and accept who they are and try to optimize their health and not miss gastrointestinal issues and discomfort and nutritional deficiencies, right? We can do both. So my closing thoughts here. You can take the road most traveled or the easy road. You can accept that a child with Down syndrome will be unhealthy. Perhaps they'll have dry skin, a flat affect, puffy eyes and large tongue, a bloated abdomen, poor hair growth, and just not feel well. Or you can take the higher road as I see it, sometimes the more difficult road. You can accept that these children can be healthy, happy, thriving, contribute to their family, and be valued and cherished by people in their community. And if these families, these beautiful families that I work with, if they're not willing to give up on their children, I suggest that we don't either. As a medical community, that we do better. And if we continue to do what has been done for these children, which in many cases is very little, we'll continue to get the same outcome. These children deserve better health. And when they get better health, their potential is definitely unlimited. I appreciate your attention today. If anything I've said today has struck a chord with you, you found interesting and perhaps helpful to others, I suggest that you share this video. If you'd like more information about our practice, you can reach out through our website at pearsoncenter.com. And again, I hope you found this video to be helpful to you, and I wish you and your loved ones health and happiness. Thank you.